The following is a presentation of Project Independence and WCWP. Project Independence is the Aging in Place initiative of the town of North Hempstead. We provide programs and services designed to assist and support the older town residents who wish to remain in their homes as they age. If we don't currently provide a service, we will try and connect you to that service. Call 311 or 869-6311 to get more information or receive services.
Welcome to Project Independence and You.
Good morning and welcome to Project Independence in You on 88.1 FM and WCWP.org. I am Rebecca Miller and will be hosting along with Kristina Liu, Project Independence in You today. How are you doing today, Kristina?
Good. Good morning.
Great. Good. It's always good to see you in the morning and, get some of this great information out there. Kristina, of course, is also the producer of the radio show and just gets the most greatest guests. And that being said, let's go to our guest today, who is Dr. Marc Gordon, who is the Chief of Neurology at Zucker Hillside, the Litwin-Zucker Research Center, and the Feinstein Institute. So welcome today. And Kristina and I both want to thank you for taking a full hour. I don't know if you know it's a full hour, but of your day.
I've been informed.
To talk to us. And we also are very grateful because you did also present at a recent Project Independence advisory meeting. And it was really, really a lot of incredible information. You had a lot of good questions. So with that being said, I'd like to hear just a little bit about your background.
Okay. So I'm a neurologist with a particular interest in what's called cognitive and behavioral neurology. When my children were little, I used to tell them I was a brain doctor. I think that's probably the best description of what I do. I do have a joint appointment in neurology and psychiatry, so I've been very much interested in the interface between sort of the hardware of the brain and the software of the mind. And my focus in my research has been on memory disorders, in particular Alzheimer's disease.
Wow. I like that, the hardware and the software. I know cardiologists use the plumber and electrician analogy too, but you kind of do a little bit of both. So just to give us a little breakdown of what's happening now in research and just to give us kind of an update because, in the past, there's not been a lot of new things coming out or that people know. So really curious to hear all about what's happening today.
Okay, so I think there's a lot going on, so far with the, I guess, less than optimal results, but we're still plugging away. And I think, to kind of put this in historical perspective, Alzheimer described his first case near the beginning of the 20th century. But it really wasn't until about the 1970s that it was recognized that the majority of elderly people who had memory problems had in fact, the same kind of pathology that Alzheimer had described with the plaques and tangles in the brain. And then since then, we've done a lot of research, I think, in terms of trying to understand what the pathophysiology of the disease, in other words, what sort of things seem to happen in the brain as the disease progresses, although I don't think we're at the stage where we really know what causes Alzheimer's disease. Mm-hmm. But as we've understood more about the way in which different kinds of pathology affect the brain, the buildup of certain abnormal proteins, something called amyloid and something called tau, as well as inflammation in the brain and interruptions in the connection between brain cells, between neurons, I think we're having an understanding of more potential targets that we can explore to try and treat the disease. Up until this point, we have some medications that have some symptomatic effects that can alleviate to a modest degree some of the cognitive and to a certain extent behavioral symptoms of the disease, but those are not thought to be disease modifying. They're really treating the symptoms not really getting at the underlying cause of disease. And we are in the process of trying to see if we can develop other types of therapies that can really change the course of disease, slow the rate of progression, or even arrest or reverse the disease.
Just a brief, maybe quick kind of differentiation, or how the difference between dementia and Alzheimer's are the same thing, because a lot of people will refer to any kind of dementia as Alzheimer's. So just for a little clarity for our listeners.
All right, it's a good question, and certainly not the first time it's come up.
Sure.
Let me say that not everybody with dementia has Alzheimer's disease, and also not everybody with Alzheimer's disease has dementia. So let me explain this. Dementia is what we call a syndrome rather than disease. It refers to a constellation of signs and symptoms. Patients who have the syndrome of dementia, that's defined as having a decline in cognitive functions in multiple domains, say memory or language or executive function, administration, how we organize our tasks. So there's a decline in those areas of function. That's a departure from their baseline of sufficient degree to interfere with their ability to function either socially or occupationally or both. So that's the syndrome of dementia. There are many, many different causes of that syndrome. Alzheimer's disease is the most common cause of that syndrome, probably accounting for about 65% of people with dementia. Now, with regard to the second part of that question, before people reach that stage of dementia, if they have Alzheimer's disease, that pathology has been developing over a very long period of time, probably more than 10 years. So there is different stages, if you will, that you could say within the spectrum of Alzheimer's disease. There's a preclinical stage when people have no symptoms whatsoever, but are starting to have some of the pathological evidence that the disease process has started. And then there may be an early symptomatic phase, which has sometimes been called mild cognitive impairment, when people have some symptoms of forgetfulness. For example, again, usually with Alzheimer's disease, the usual presenting symptom is forgetfulness, but it's not of sufficient degree to interfere with social and or occupational functioning, hence would not reach the definition of dementia. So that would be prodromal Alzheimer's disease or mild cognitive impairment. And then as people get further along in the stages, they may develop dementia, which we can further categorize as mild dementia, moderate dementia, severe dementia, different stages along that spectrum of Alzheimer's disease.
Okay, well, that's a pretty good definition. And I know when I was telling my mother that I was doing this program and what we were going to be talking about, she hears a lot about, and so do a lot of people, are there things that we do every day that could trigger it or, cause it temporarily, like foods with preservatives or, or things that they use on poisons that they use on the property and landscaping? Like, are there changes that people can make in their day-to-day life that might help not to bring it on, or at least not bring it on quickly?
Mm-hmm. All right. So to a certain extent, let me say that there may be some genetic predispositions, and I should back up one step and say very rarely there are actually inherited cases of Alzheimer's disease, but that is a very small minority where people have certain mutations that can, be inherited with a 50-50 probability of an affected parent of getting disease. But most cases are what we call sporadic, so it's not something that happens clearly. However, there may be contributions of variations in a lot of genes that may affect your underlying genetic disposition. But it's not, again, purely genetic, and most of the disease is not really heritable. But there may be an interaction between a predisposition and your environment. Now, there are no known specific toxins that have been implicated in Alzheimer's disease, although there have been studies that suggested that exposure to air pollution may be a risk factor. There are some, however, lifestyle modifications that people, have linked or at least have been associated. For example, midlife obesity is a risk factor. So I would say if I had to sum it up, in terms of what you can do, probably your mother was right. You should, eat well, okay? You should be socially active. You should be physically active, and you should be mentally active. So you should keep your brain stimulated. All of these things have been associated with lower risks of developing dementia in general and Alzheimer's disease in particular.
Oh, so important. That's really good to know. Dr. Gordon, can you tell us a little bit about, or a lot actually, about the programming over at Zucker Hillside Hospital?
Sure. So I've been fortunate to be able to work in this translational research center for the study of Alzheimer's disease, the Litwin-Zucker Center. It was funded through donations from Leonard Zucker and Barbara and Donald, Leonard Litwin and Donald and Barbara Zucker, who have been very generous in getting us started. And we've been, doing this, I think, since 2004. And now we have developed funding from, NIH and NIA, government funding agencies, as well as collaborating with industry to study Alzheimer's disease research. I mentioned that it is a translational research center, so there are people on the floor below me that are working with cells and with animal models, and I actually work with human beings and other my colleagues here. The nature of our research we could divide into observational sorts of research, where we're trying to follow people and see if we can identify particular risk factors or what are called biomarkers, things that we can measure that may tell us who is at risk for developing cognitive problems down the road. And that might allow us to predict and also, as I'll get to, potentially intervene earlier on in people that we think might be at increased risk. The other thing that we do is, aside from observational studies, are interventional studies. That means we're trying to see whether we can come up with medications better than what we already have, which I mentioned before are really only symptomatic medications, to develop either medications that better treat different symptoms, or even ideally change the trajectory of disease so that we can slow the rate of decline or even arrest the course of decline in people with that disease. So at any given time, we may have a number of different studies going. Currently, we have one study that's looking particularly at the behavioral symptoms of the disease, and that's for people who have more moderate to severe stages of dementia, where they tend to have more behavioral problems, agitation, and or psychosis. But as well, we're looking at patients who have prodromal stages of the disease, the very early symptomatic stages where they're having some forgetfulness, but don't have dementia or have the very mildest form of dementia. So, for example, we're involved in a large multi-center study with the medication semaglutide, which is already on the market for the treatment of diabetes. We're studying that medication for patients with prodromal Alzheimer's disease because there's some evidence that it might be useful for the treatment of Alzheimer's disease in terms of preventing the inflammation in the brain. And we do have a study with a drug which is on the market for multiple myeloma, which we're trying to repurpose. That's called daratumumab, which we're trying to repurpose for the treatment of Alzheimer's disease. And that's a study that we're looking at for patients who have mild to moderate Alzheimer's disease. So that's some of the things we have going currently. We are always looking at new studies. I can't talk about another one because we haven't signed the contract yet, but another study that we have up and coming. And certainly we're always looking for people who may be interested in participating in studies. As I said, sometimes we have studies that are designed for different stages of disease. And we also have studies where we're looking at patients who are cognitively healthy. We've got another study going on right now where we're basically studying the tests that we use to measure change to make sure that we're actually seeing people getting better as opposed to people that are just getting better at taking the test because they've had more practice. So,
Doctor, how do you become a participant? How are you, I mean, because you're not a regular doctor office, how do you get patients at all these different levels?
Yeah, so some of our patients are referred to us by clinicians within our healthcare system, and other patients contact us or their families contact us directly. And again, our phone number here is 516-562-3492. And again, if you're interested in participating in a research subject, or you have a loved one that you think might be able to be benefited by being in a research study, just give us a call. We can go over what the criteria are for entry in the study, or we can refer you to all of the studies we do are posted on a government website called clinicaltrials.gov. That tells what studies are available and describes them. And again, if we're interested, and again, you seem to be an appropriate candidate, we can arrange a screening visit to come in to our center.
Dr. Gordon, in promoting, you being on the show, a lot of different questions came in, and Beck's been hitting a bunch of them. And I think, are all the studies, depending on the type of study, different time frames, or some, monthly or yearly? How does that's just something ahead of time when you're getting involved in the study?
Yeah, well, before anybody participates in the study, we first of all send out information, and then there's what's called an informed consent form where people go over it in detail, and it spells out, what does the study entail? How often do you show up? How long will your participation be? What do you have to do when you're in the study? What are the potential risks of being in the study? What are the potential benefits of being in the study? And a lot of language about confidentiality. So again, I want to stress that it is an informed consent process to the extent that the patient themselves are able to consent on their own behalf. We would certainly go over that with them. And in instances where a patient has more advanced disease and does not have capacity to consent on their own behalf, we would potentially obtain consent from a legally authorized representative that might be their healthcare proxy or somebody designated as having a power of attorney for healthcare decisions, and go over things with them. Again, it depends on the study as to how often the visits are. And, again, some of the medications I've described are pills. Some of them are injections into a vein. Some of them are injections under the skin. So different criteria, different frequency of dosing, different.
We have to actually take a quick break. I'm sorry. We're speaking with Dr. Marc Gordon, Chief of Neurology at Zucker Hillside Hospital. We'll be right back.
WCWP is your home for great music and great conversation. You'll find all that and more on WCWP.org. Listen live on the web, check out the lineup, subscribe to podcasts, and stay up to date on the latest station events. Get in touch with us and let us know if you like what you're hearing. And find out how you can support or get involved at the only community public radio station serving Nassau's North Shore. Plus, sign up to get a free bumper sticker. It's all online at WCWP.org.
And welcome back to Project Independence in You on 88.1 FM and WCWP.org. We are speaking with Dr. Marc Gordon, who is Chief of Neurology at Zucker Hillside Hospital. Dr. Gordon, before the break, we had to kind of cut you off in the middle of a big explanation. So if you want to just kind of back up a little bit and just return to what we were discussing.
So the question had been, there are different studies, how long might you have to come in, what do you have to do? And as I said, there's a consent process from either the subject to the extent that they are able to consent on their own behalf, or if they lack capacity from a legally authorized representative. But basically, we would go over what the drug is, what the study entails, how many people are in the study, how many visits there are and how often you need to come in, and what the duration of the study may be. And some of our studies go on for up to 3 years. Actually, one of our observational studies, I'm seeing somebody later today that for their 12th year visit. So,
wow.
And some of the studies are of much shorter duration, 6 months, 9 months, 12 months. Again, it depends on the particular study. Certainly, you would know that going in.
I'm curious about one thing, kind of jumping around a little bit. Hope that's okay. With younger people, I mean, I know that there's not a huge number, but when someone is younger and they do get Alzheimer's, which you do hear about, is there commonality between younger people when they get it? Like, is it, I don't know, I want to say, like, are they heavy drinkers, or is it just some random thing that is unexplainable that happens? Because it's not, you're kind of used to hearing it happening, and it almost kind of makes sense as we get older, everything ages. But when somebody gets this kind of, condition or syndrome that is really, they're young, their body hasn't gone through what other adults, seniors have gone through. So just curious if there is a commonality when it hits young.
All right. So first of all, just to reiterate, age is probably the biggest risk factor for Alzheimer's disease, and it does have an age-dependent prevalence. That the older you get, the higher the risk, until you get to the very old, when you tend to have more vascular causes of dementia. We mentioned before that there are familial forms of Alzheimer's disease. There are rare autosomal dominant forms of the disease, and those tend to be younger onset. So I, did have a patient who was in their 30s when they developed their disease, and they had a parent who was affected also in the 30s. So that's the very early onset. We still say that anybody under the age of 65 has early onset Alzheimer's disease. And I think, in terms of causality, there might be more of a genetic predisposition in the younger people than in the older people, rather than any particular environmental exposure in those younger folks. There are also some differences sometimes in the presentation of the younger people, that they may, for example, tend to have more psychiatric symptoms earlier on than the later onset disease. Again, other differences that they tend to have fewer so-called comorbidities. They tend to not have the other normal aging things going on that, heart disease that we may see in older people with Alzheimer's disease.
Right. Okay. Thanks for that. So going back to the programs and the research over at Zucker Hillside Hospital, what's involved in terms of cost and insurance, or is there no cost involved? Okay.
So all of the research that we do, there is no charge to anybody for the research part of it. Now, if you're seeing somebody, for a neurologist in the community or part of our health system for routine medical care, that's not picked up. But if, for example, you're involved in a clinical trial, all of the testing that we do as part of the clinical trial is included at no cost. All of the study medications are provided at no cost. There's no additional cost to the patient or their insurance for the research component.
Oh, that's good to know. In terms of kind of, there's always involved, of course, a caretaker too with someone who has Alzheimer's. And we talk about this all the time. Sometimes when someone's taking care of their husband or, wife, they don't really understand that they're a caretaker. They're just taking care of their spouse. But I mean, there is that's a primary caretaker role that, people take on. Is there any programs? Is there like support, like psychological support or respite care that's also involved with any of the programs that you do?
Okay, so our center is primarily a research center, and we are not involved in providing social work services. We don't have anybody here like that, but we're part of Northwell Health, and Northwell Health is a big organization, and we have close relationships with between neurology, which is my primary department, as well as psychiatry, and some of my colleagues here at the research center are psychiatrists, geriatric psychiatrists. We also collaborate with our geriatricians. They have social work programs both through geriatric psychiatry and as well as geriatric medicine. So there are resources within our health system, although they're not specifically out of our program.
Would there be someone you wouldn't feel is right for the program, someone who has Alzheimer's and, in that way fits the criteria, but maybe they have other health issues that would just be too hard to kind of do at the same time?
So again, each individual study has its own inclusion and exclusion criteria.
Okay.
You have to say you have to be within a certain age range, and you have to score within a certain range on some of the screening tests that we do. But there are some medical exclusions that are often come up, so that if somebody is deathly ill from some other disease, then engaging them in a study that might last a year or 3 years, doesn't really make any sense. So there may be exclusions, and again, people have to be, you raised the issue of having a caregiver. So most of our studies require a study partner. It doesn't necessarily have to be the caregiver, but it usually is the caregiver, whether that is a spouse or an adult child. That is also participating in supervising and also giving us feedback as to how the patient who's the subject of the study is doing. So again, those are some of the criteria that come into play. It's so hard. I don't want to say hard to believe. I mean, it is what it is, that we don't. Not that we don't have a clue, but are we kind of coming closer to I guess we don't know why we get it, but an understanding as to what's going on? I mean, you hear so many things, so many conflicting articles. It's constant, and I'm glad how much research you all are doing, because that's really what we need. But, you hear these hopeful articles, and then, you hear how some medications are working, how they work for some people under certain situations. But is there any, do people have a little clue as to why? I mean, obviously we know the risk factor is aging, but, with all the MRIs and everything, it's just, how close are we to really understanding why it happens? In your opinion, I think we're understanding a lot of how it happens, what processes go on. I think the why is still an unanswered question and may not be a single answer. But I think we have learned a lot. Unfortunately, we have yet to translate what we've learned into a disease-modifying medication that's been proven to have a significant clinical effect. Our failure rate in clinical trials for Alzheimer's disease is way worse than cancer. And there remains a lot of work to be done. But I do think we are making slow and steady progress. So I think there tends to be a kind of, roller coaster effect in terms of what people read in the news, that, somebody finds something that was that seemed to show some benefit in a mouse model, and the next day, I'm getting phone calls. Can I give this thing that was studied in mice to my parent, or my husband or wife? And I have to explain that people aren't mice, and we need to, see if we can actually develop it. A lot of things that worked great in mice didn't pan out so well when we gave it to people. So it is a long and and laborious process, but I think ultimately I think will be rewarding. So I don't go into this every day feeling a sense of futility. I do feel a sense of hope, but I don't necessarily know that hope is for what's going to happen tomorrow. Okay.
Right. So we're getting closer.
Yeah.
Well, and the fact that you said it wasn't really recognized until the 70s, that's not that long ago.
Yeah.
Right.
It's actually, I had no idea. That was something that I certainly learned today.
Yeah, I mean, it was thought until the early 70s that it was a rare cause of pre-senile dementia. And it really wasn't until the 70s that we recognized that the majority of people with older people with dementia had Alzheimer's disease pathology.
It's so amazing to me with the brain is this organ. And I remember growing up, hearing in science and, that we only actually use a very small percentage of our brain. And I wonder if that's true and why. Why can't we use the rest of it? What's happening there?
Yeah, I'm a neurologist and I've really never understood what that means, because
I'm glad you said that.
because there's a lot of things that we do that we're not necessarily conscious of. That doesn't mean we're not using the brain.
Right. Okay.
So I think there's a lot of sci-fi things. If only we could utilize more of our brain, then we'd all be super geniuses. I think that's
Right. Yeah. Okay. I'm glad you clarified that because I always wondered. I think it's such a waste. I've got such a 90%. That's just what's it doing? If it's there, but it's not.
It's doing a lot of things that you don't have to think about.
Yeah, I'm sure, and that's cool. I don't need to know what it's doing, but I just just the thought that it might not be doing something that it should be doing.
Right.
But it is fascinating, and all the research that you're doing is just it's just amazing. And
Dr. Gordon, with all these research, I know you said that there's currently 3 different studies going on. Now, are those still open for people who are interested to participate?
Yeah, those 3 studies that I mentioned in particular, the DARZAD study, which is the one that is studying that injection that's on the market for multiple myeloma to see if it might be helpful for Alzheimer's disease, that is open for enrollment. The EVOKE study, the semaglutide medication that's on the market for diabetes, that is open to enrollment. And the ASPECT study for agitation is open to enrollment. And as I said, we're always, looking at other potential studies, relatively selectively, but things that we think look particularly promising and novel are things that we tend to develop. So those are open to enrollment. And I also want to mention that our longitudinal study, where we're following people over years, I mentioned that we're going to be seeing somebody for a year 12 visit later today. That is, I think, still in some of its segments open to enrollment. We are still recruiting for that study that's looking at testing the tests. Okay, so I only mention things that are open to enrollment.
Okay. Great. Okay.
I'm looking at the age range in a lot of the different trials that you do, and for the most part, it looks 55 to 85, and 55 seems young, but I guess you got to start somewhere. And also with the for the agitation type of study that you're doing, that's a broader range. That's a 50 to 90. So I'm just curious as to how you come up with the age ranges for these studies.
So first of all, some of these are multi-center studies, so it's not necessarily our decision,
Okay.
but generally speaking, when we've called it, and again, as you see, I think there's often a fair amount of overlap. We're looking, below 50, we might be dealing with a different disease process, more of a, an inherited disease rather than the sporadic Alzheimer's disease. As we talked about, there are some earlier onset cases. I think the concerns at the upper age limit are, first of all, if we're doing a 3-year study and we're, looking at people who are 95 at baseline, for other reasons, they may not be around long enough to figure out whether these medications work, and they may have more comorbidities. Plus, as I mentioned, in the very old, I think there may be more mixed dementia where there's not only Alzheimer's purely, but a combination of Alzheimer's and vascular disease. Actually, one of the studies that we're doing does allow a certain amount of overlap between that because it's not necessarily strict categories that somebody has disease A or disease B, but they may have a combination of both pathologies. Again, most often circulatory changes, vascular and Alzheimer's pathology.
Very interesting. So in terms of people who are interested for any of these programs, they'll just call that number. We actually have to take a quick break. We're speaking with Dr. Marc Gordon, who is the Chief of Neurology at Zucker Hillside Hospital, and we will be right back.
Take WCWP with you wherever you go with the WCWP app. Listen live 24/7 to all of our streams, all from one app. Plus, call the studios directly from the app and visit our social media. Download the app through the iOS App Store on Apple devices or the Google Play Store on Android by searching WCWP Radio, or visit WCWP.org for links. The WCWP app, available now on iOS and Android devices.
And welcome back to Project Independence in You on 88.1 FM and WCWP.org. Project Independence in You, Community Talk Radio. We have Dr. Marc Gordon, who is Chief of Neurology at Zucker Hillside Hospital, the Litwin-Zucker Research Center, and Feinstein Institute. So we're really thankful for you being here and giving us so much of your time. And I know we want to repeat the phone number because you've given us so much information, and if anybody is interested in contacting Dr. Gordon and the program at Zucker, what was that number again?
It's 516-562-3492.
Great. So over break, we were kind of talking among ourselves to kind of like really kind of present to our listeners I want to say positive things. Like, you've come a long way to, I guess, like Kristina was saying, it's hard to believe that it was just kind of named in the 70s, in the early 70s.
Well, it was named earlier than that, but it wasn't really generally recognized as a common disease until the 70s.
Okay. Right. And at that point, I don't want to say, was it hopeless? Like, where were we then? And like, look at where we are now and all these trials and the medications that people are taking. So what are some of the medications that are looking hopeful or have provided, some good, interesting results?
All right. So let me say, first of all, that for the first part of my career when I was in medical school and residency and up until the first couple of years in practice, there were no medications approved for the treatment of Alzheimer's disease. And it really wasn't until the 1990s that we had the first class of medications that are called cholinesterase inhibitors, donepezil, rivastigmine, and galantamine, and then subsequently one other class of medications, which is an NMD receptor antagonist called memantine. So those were the medications that came out. As I mentioned before, they have modest symptomatic effects, but no real evidence of disease-modifying effects. There is one drug which had a very controversial approval recently as a quote-unquote accelerated approval as an anti-amyloid antibody called aducanumab, which was shown to remove amyloid, which is a biomarker for Alzheimer's disease, from the brain, but was not shown to have a significant clinical benefit in the pivotal trials. So that medication is approved, although the government actually won't pay for it being administered, except in the context of a clinical trial. And again, there's a whole long story. The drug was approved, the advisory panel to the FDA voted 10-0 with one abstention against approving it, but it was approved anyway through this accelerated program. And again, CMS, their coverage decision was that they would only cover it for in the context of clinical trials. So that's kind of where we're at. But as mentioned, there are a lot of other targets, targeting amyloid, this abnormal peptide that accumulates in the brain, targeting tau protein, and we've done clinical trials with antibodies targeting tau, as well as other potential targets involving inflammation. And, again, I could talk about some of the studies that we're doing in particular. I alluded to them before. So, for example, we have the EVOKE study, which is a study of a medication called semaglutide, a medication that's already on the market for the treatment of diabetes. But there is some evidence that people in clinical trials for that medication, taking the active medication as compared to placebo, had lower rates of developing dementia. And again, not through any mechanism in terms of blood sugar, but perhaps through effects in terms of inflammation in the brain.
Dr. Gordon, I have a question. So you talk a little bit about, and there's a lot of this, someone who, when you find a medication that, is someone who has diabetes, and you're finding that, wow, that has a positive, could potentially have a positive impact with someone, who also has Alzheimer's. Is that like something that you kind of look at the drug and say, oh, that's probably could help? Or is it something where someone has diabetes and it seemed to help with their Alzheimer's?
Yeah, so it's not, I think there was, when we try to, as you say, repurpose a drug, it's not necessarily because of their effect on the disease that it was originally approved for. But the medication may have other effects which are potentially useful. So I think there's a combination. There may be sort of epidemiological research that say, hey, we noticed that in the clinical trials, this isn't what we were looking at, but we noticed in the clinical trials that the people who got the active medication as compared to a placebo had lower rates of developing cognitive problems. Maybe that's something we should look at. Or there may be animal data using this drug that looks at some of the things that we know about biomarkers of disease, the pathophysiology of the disease, that says, hey, this could be potentially useful because this drug also affects pathways that could be important in the development of Alzheimer's disease. Okay. So I think it's a combination of those two lenses that may lead to developing a hypothesis as to whether a drug might be useful. And then, there are different stages of drug development where there's some early testing and dose finding, and then some later, pivotal trials that could lead potentially to an approval by the FDA to get the drug on the market.
Is there a limit to how many people you can have per study, or is it just kind of like an ongoing thing? I know that you had mentioned you have one study that's in its 12th year now.
Yeah. So that's a more open-ended observational study. For the interventional studies, there is, based on a calculation on how many people you would need to have to achieve, statistical significance, or at least to be able to test a hypothesis. They figure out, how many people would you need to have in the study. Many of these studies, like the one I was mentioning, this study of semaglutide, is a study that's being done internationally with many sites around the world. Actually, there are two similar studies being done in parallel, and literally a few thousand people that will be enrolled in the study, some of whom are going to be randomly assigned to be taking the active medication, and some of whom will be randomly assigned to be taking a placebo. That particular study, like many studies of that kind, is what's called a double-blind study, which is to say you don't know whether you're getting the active medication or the placebo, and the study team doesn't know whether you're getting the active medication or placebo. So that's the only way we can really test the hypothesis as to whether the drug works, whether people who don't know what they're getting do better than people with the active medication, do better than people who are assigned to the placebo medication. Another study that we're doing, DARZAD, is as an open label phase 2 study. That means everybody's getting the active medication. It's a much smaller study where we're looking for 15 people to kind of look for some preliminary evidence as to whether, compared to some historical guidelines, people seem to be doing better than we would have expected. So that's a much smaller study in terms of the number of subjects. So again, depending on the particular study and the study design, there will be a finite number. That number is part of the informed consent process to say we expect to enroll this many people in the study.
So just another curious question that I have. So since you're part of the study over at Zucker, and it could be an international study, if you find something that is effective, that's doing something, how long is that process from, hey, this is working, to when someone can actually, it goes to the shelf, it goes to the pharmacy, docs can start prescribing it?
Yeah, it's a very long process, because you start with, testing compounds, and looking to see whether there's any signal, and you have libraries of compounds. And this is not something that I do. This is more preclinical stuff.
Right.
And to see whether this thing that you might have some plausible mechanism of action, then you can test it in an animal model, in a mouse, and see whether there's results. And then you can do some preliminary studies in people, to just in terms of safety. And then you can do some dose finding to see, if we were going to use this medication, what dose seems to be safe, but also have a potential. And then you have a study that really tests the hypothesis: does this really make people better or not? And so that process can take a very long time. You may have noticed that the two studies I mentioned here, the EVOKE study and the DARZAD study, are using medications that are already on the market and repurposing. So that allows us to shortcut a little bit, because we don't have to spend 5 or 10 years in terms of the preclinical development. We already know what the effects are in animals and in people, okay? And we know what potential precautions we need to take and what we need to look for. So we have, that helps us, if you will, cut out some of that time. Then after the medication goes through, the rigorous testing, then it has to be submitted to the FDA, and that process, again, can take a certain amount of time. And then if it's approved, on the market, then it's fully available.
We have, I guess I'm curious, most guests we have on, we always ask them, how COVID impacted their programs, their process, their patient, their whatever situation, you were in. But, my question is kind of twofold. So how did that impact your research with COVID and people being afraid to come out, or, hospitals with all the rules and regulations, and also, did COVID affect people, the way people are thinking? I mean, you hear so much about fog brain. I have had COVID twice, and I have fully vaccinated and boosted, yet I definitely have a much foggier way of thinking. And I'm not getting older, so it can't be that. But so I'm just curious, like the whole COVID situation and your research, because I'm sure there was an impact there, and also the kind of clinical impact it had on people, if it did, in terms of Alzheimer's. And
so obviously COVID has had an enormous impact on all of us, and for the first several months we were more or less in lockdown, so we could not bring people in for a period of time. And I think people were reluctant to come in, for a longer time thereafter. Again, a lot of the processes that we had, when we're doing a multi-center study, all of our monitoring got converted to remote monitoring rather than people actually coming to visit us and going over our records on site. I think, I think people had concerns about taking medications that might have effects on the immune system, that had, concerns about taking, medications that might need to be injected. So I think that certainly affected us. I think it also kind of fragmented our relationship with the community. We used to do, as you're aware, screening events in the community, which were interrupted, where we're trying to identify people who might have cognitive issues that they were not aware of, or might have been aware of but didn't really acknowledge or endorse. So I think we have been very much cut off from the community in lots of ways. I also serve as vice chair of the Institutional Review Board that observes, research in our health system in general. And I can say that every study has had problems with recruitment and enrollment because of COVID. Logistical processes and people being reluctant to come in for visits when they're not acutely ill. So
were you able to switch any of it virtually? I mean, there's so much we can do today, monitoring people at home, and certainly maybe intake and things like that. And if you did do stuff virtually, is that something that you might be continuing with? Because people are reluctant still. Yeah.
So again, I think there's a lot of stuff that we need to do that's hands-on. I can't give an injection, over Zoom. We can't do, even if it's pills, we can't do pill counts easily over Zoom. In the throes of the lockdown, I think there were some things where we could do some of the rating scales over the phone. Okay. But only some of them. There's issues in terms of validity. If you're asking somebody to do a test where they need to write something or use a tablet or something, that's a lot of work to try and figure out how to do that remotely. I think that we're welcoming the fact that, and unfortunately, a lot of people now are fully vaccinated and boosted, and we certainly encourage everybody to do that. It's important for your general health. And getting to your second question, which is, the effects of COVID on cognitive health. Yes, there is this issue of long COVID and so-called brain fog. And people have expressed concerns that will we be seeing, an effect many years hence of increased rates of dementia and might, having been exposed to COVID, be a risk factor for developing, Alzheimer's disease later on. We don't know that yet. Time will tell. I think that might be a time when we need to wrap this up, judging from that hand being raised in the background.
Well, it doesn't take away from all the good work that you're doing. And, I definitely know we're going to remain partners. We have, our nurses from Northwell that are subcontracted for our residents of North Hempstead. And, we definitely will have to have you talk to them, and they may have people in mind too. So thank you so much for giving so much of your time on the show and also at our advisory meeting. So much information. Great speaking with you, Dr. Marc Gordon, who is Chief of Neurology at Zucker Hillside Hospital, the Litwin-Zucker Research Center, and the Feinstein Institute. Thank you so much for joining us.